I want to introduce Dr. Cantu. So Dr. Cantu is one of the co-course directors here and really one of the fathers of concussion medicine in sports. So Dr. Cantu really was the father of concussion grading scales many years ago. They're now a little bit out of favor as we've sort of moved on to different ways of looking at concussion. He's the chief of surgical services at Emerson Hospital. He is also now an adjunct faculty here at Children's Hospital and widely recognized around the world as one of the leading concussion experts in the world. So Dr. Cantu.
Thank you, Mark. It's my pleasure at this point to kind of kick off the meeting and to reflect that back just a few years when I first met Ann, there were two chronic traumatic encephalopathy brains that she was working on at the time, one of them in a boxer that I actually had seen fight for a world title right here in Boston. Now, a very few years later, she has gone from associate professor of pathology at Boston University neuropathology to be professor of everything neurological in the world, I think. She's world-renowned. We're running behind. I'm not going to take a lot more time introducing her, but to tell you, though, you are in for a very, very special treat because part of her renowned traipsing around the world will be the Zurich 4th Annual Concussion Consensus Conference, where she's going to present largely the same material, I suspect, that she's going to give you the heads up on this morning. So Ann, come forward and tell us about all things CTE.
Well, thank you, Bob. It's an honor to be here. Dr. Proctor, Dr. Cantu, thank you for inviting me again. And I am going to give you a whirlwind tour of what we've learned about CTE in the last really 4 years. I want to start out by saying I'm a neurologist and a neuropathologist, and why I think that's important is because this is a very sort of classical study. It's called clinical pathological correlation. It's really one of the oldest ways of studying disease that we've known about. And because this is an autopsy series, because I'm going to tell you about this disease based on the brain donations of athletes and veterans, there is I cannot make any comment about the incidence or prevalence of this disorder amongst living athletes and veterans. This is a very biased study. Just the nature of an autopsy selects for people that have diseased brains, even though we take all comers. But I will show you what we found in terms of their clinical symptoms and the spectrum of their neuropathology. I want to say, at the beginning, I have to repeat this a lot. I love football. I'm not out here to get rid of the game of football. I grew up right outside of Green Bay, Wisconsin, and that kind of childhood gears you in a way or changes your life in a way that you love football. And of course, I do, apologies, love the Green Bay Packers. But I'm going to talk to you today about the brain donation registry and what we've learned with the CSTE Brain Bank. And this is work that I've done in collaboration with Bob Cantu, as well as Bob Stern, a neuropsychologist from Boston University, and of course Chris Nowinski, ex-Harvard football player and ex-professional wrestler whose own personal saga with concussion and head trauma was the stimulus for this study. I'm going to talk to you about the TBI Brain Bank. We started out, as Bob said, with just a couple of brains. We got about 10 the first year and about 10 the second year. And now in our 4th year, we have over 114 brains into the brain bank. Not all of these have been examined, but about 80 of them have. And I'm going to tell you the results of those 80. This is not a new disease. This is a disease that's been around since the 1920s. It was first described actually by a pathologist who, interestingly enough, did not describe the pathology. He described the clinical spectrum of disease that he noticed in boxers. And he said it affected nearly half of the fighters who stayed in the game long enough. And when Bob and I started this study, I thought one of the most important things to do would be to review the world's literature. What is known about this disease, CTE, in the literature? And so back in 2009, we reviewed the world's literature and came up with 48 cases of CTE with neuropathological verification. And you can see that at that time, most of them had occurred in association with boxing. There had been a few reports in association with football, and there's been other various activities that had resulted in CTE. At that time, we had 3 in our brain bank. And just in the last, this should say 2012, obviously, I'm going to tell you about the 65. So we've already more than doubled the world's experience with this disease, and as you can see, we are seeing this in a lot of football players at all levels of play, professional, college, as well as, unfortunately, sometimes high school players. We're seeing it in other sports, including hockey and wrestling and rugby, and notably, we're seeing it in military veterans. And I have an asterisk here because this is not a mutually exclusive group. Most times, military veterans are also athletes, and athletes are also military veterans, so they have often combined exposures. I'm going to go through just what are the clinical symptoms of CTE and what are the pathological changes, and then I'm going to show you some relevant case studies to emphasize these points. So the symptoms of CTE usually begin well after the person's retired from the sport or well after the head trauma. The usual interval is about 8 or 10 years after retiring from the sport. The first symptoms tend to be emotional and behavioral. So there's a personality change. Some of the early symptoms are irritability and something called a short fuse, meaning that, a trivial event that might not have provoked an aggressive or hostile reaction earlier is now very irritating and causes sort of an overreaction. There may be a change in terms of aggression or violent behavior, sometimes a tendency towards verbal and even physical abuse. Impulse control problems are common, as is suicide. Suicide is seen. Mood changes, mood instability, vacillating between depression and sometimes euphoria, other things that we have seen in this population. These are accompanied very closely by memory problems. So short-term memory loss is an early symptom, as is executive dysfunction or problems with planning and organization and judgment. And then as the individual ages and the disease gets more severe, you start to see full-blown dementia, problems walking, problems with speaking, Parkinsonism, and we've also seen a subset of these individuals, about 12%, who develop an ALS-like or motor neuron disease. The pathology of this disease is extremely unique. It's not seen in any other neurodegeneration, and it's not seen in any other tauopathy. I'm going to show you this in case examples, but you'll see that there's brain atrophy in CTE. There's shrinkage of not only the cortex and the medial temporal lobes, but there's dilatation of those inner chambers containing the spinal fluid within the brain. And then you'll see a massive buildup of a protein called tau, phosphorylated tau, that builds up as it appears dark brown in the preparations we use, but it appears as a dark brown buildup in nerve cells and also the nerve cell processes. So there's just this incredibly dense, chaotic network of abnormal tau protein in the cells of the nervous system. And we also see, in addition to the tau protein, abnormalities of another protein called TDP43. Just to go through what are some of the gross pathologic changes of CTE, you see ventricular dilatation, not only of the lateral ventricles, but also disproportionately of the third ventricle. So this is a characteristic feature, the disproportionate enlargement of the third ventricle. You can also see this thing called the cavum septum pellucidum. Instead of being a single leaflet, it's a double leaflet, and it can become quite wide. And you also see shrinkage of the medial temporal lobe, that is the amygdala, the hippocampus, and the entorhinal cortex. In advanced disease, there's shrinkage of this part of the brain, and that septum not only can become cavum, but often in the severe cases it is fenestrated, or it has many holes in it. In fact, in this individual, it's basically absent. It's just being held up by a few remaining blood vessels. And that's another thing we see in some of the older athletes, especially the complete absence of the septum pellucidum. This is just another example of some of those fenestrations seen in a retired NFL player. And we also see, in addition to the septal changes, degeneration of the substantia nigra, or the part of the brain that gives rise to symptoms of Parkinsonism. So that's another key feature of the disorder. If we look at it microscopically, we see buildup of this tau protein. And I'm going to show you brains of normal individuals first, because I've been studying the brains of the Framingham Heart Study cohort for 15 years. I've been always interested in tau protein, really since I began neuropathology. And we do use this fairly unique technique of taking a half section of the brain. So this is a half of the human brain. It's been cut at 50 microns and stained for tau protein, as well as this purplish color just to bring out the cells. And you'll see that in a cognitively intact individual, such as these two 60-plus-year-old gentlemen, there's very little tau buildup in the brain. You can see just a little bit in the entorhinal cortex. And in fact, if you look at many, many cases, as I have with the Framingham study, unless they're developing a neurodegenerative disease, there's extremely limited tau, phosphorylated tau buildup in the normal human brain. And I've done this on all the Framingham Heart Study patients, and I've never seen anything like I'm going to show you in the athletes and veterans. This is what CTE looks like. This is the brain of Wally Hilgenberg, played 16 years for the NFL, and you can see these dark brown deposits of tau deposited irregularly throughout his frontal cortex as well as his temporal cortex. You see profound abnormalities in the amygdala, also those medial temporal lobes like hippocampal structures. You'll see that it's a very erratic deposition in the cortex. It tends to collect at the depths of the cerebral sulci. That's a very distinct characteristic of this disease. The intermittent sort of lesion, and the lesion being worst at the depths of the sulci. You can see in advanced cases that it affects widespread brain structures, including the thalamus, which is profoundly affected, hypothalamus, and even the brainstem develops profound tau abnormalities throughout its extent. If we look at, these are the brains of 3 ex-NFL players, all who died at various ages. And you can see that the evidence is that this is a progressive disease, that the longer the individual lives after the exposure, the more severe the disease becomes. So there's less disease in the 50-year-old that died. There's greater involvement of the frontal cortex and the rest of the cortex in the 66-year-old. And by the time the 78-year-old died, there's disease really in every single part of the brain. It has a very distinct microscopic appearance, not seen in any other disease. And the first change and the earliest change we see of CTE is this perivascular change. This isn't a hole in the brain. This is actually a small blood vessel. And this circle, this circumferential spread of tau inside nerve cells and glial cells is a hallmark of this disease and one of the earliest features of this disease. And this is what we even see in some teenagers. You'll also see in the examples I'm going to show you that it has this matted, very intense abnormality at the depths of the cerebral sulci. And in areas away from these, what I would call hot spots, you'll see that it's a superficial spread of tau throughout the superficial layers of the cerebral cortex. I'm not going to go belabor this point, but it's distinct. CTE is a tauopathy. It's not the only tauopathy of the brain. There are about 20 tauopathies, but it is a unique pathologic disease that's very distinctive from any other disease that's been described, including Alzheimer's disease. So Alzheimer's disease is characterized by the buildup of tau, but in all cases it has massive amounts of something called beta amyloid protein, and the beta amyloid protein shows up as these, in this preparation, as these red staining plaques, and the tau is these tangles. In most cases of CTE, even though this tissue has been identically stained for both A beta and tau, there's no A beta in the CTE brain. In fact, The only cases we see beta amyloid protein in CTE are the older individuals where the beta amyloid deposition is significantly associated with age. The other feature about CTE and Alzheimer's disease is CTE is a superficial involvement. This is the peel surface of the brain, or the top of the brain, and you can see it affects the surface of the brain, and it collects around small blood vessels, which is very distinct from the pattern we see in Alzheimer's disease. The first case I ever saw in a football player was the case of John Grimsley, who had had 9 years experience playing for the NFL. He retired, as is very common, in his early 30s, and he was fine, doing well. He had his own hunting and guide business in Texas until about age 40, when his wife, who had known him for many years, noticed that he just wasn't the same individual that she had married. He was having problems paying attention to things, problems concentrating, a lot of difficulty multitasking, and also problems with his memory. In fact, their son came home one day and told him he was getting married. Occurred in the morning, and by the evening of that same day, John had forgotten that his son was getting married. So she knew that he was experiencing some changes, and when he died accidentally at age 45 from a gunshot wound to his abdomen, which he experienced while cleaning his gun, she made sure that we got his brain. And this is the brain of John Grimsley at the age of 45, stained for tau protein. And as you can see, he has massive abnormalities in his cerebral cortex, in his frontal lobe, in his temporal lobe, in his amygdala, in his hippocampus. This is massive neurodegeneration. It's the likes of which I have to say I'd never seen in a 45-year-old prior to seeing this brain. And then if we compare John Grimsley's brain to a boxer, the boxer that Dr. Cantu described, who died in his 70s, you can see that John Grimsley, even though he was 30 years younger at the time of his death, was well on his way to the advanced CTE, the advanced end-stage disease that we'd found in the boxer. As a reference point, now that we have over 65 cases of CTE, this is the worst case I've ever seen. This is an 80-year-old ex-NFL player who died after he had 14 years in the NFL. He died with very profound dementia. He had such severe cerebral atrophy that his brain was literally half the size it should have been, only 800 grams, which is remarkably small. You can see widespread septal abnormalities. He didn't have a posterior septum. His medial temporal lobe is extremely shrunken. In fact, actually, the entire brain is miniaturized. And this is his brain microscopically. There's tau flooding every single structure of the brain. There's literally not a single part of the brain that wasn't characterized by massive abnormalities of tau. You can see that there was a perivascular distribution. It was worst at the depth of the sulcus, but it was severe, very profound end-stage disease. A more recent case, this is the case of Dave Duerson, who you remember played for the Chicago Bears and had been a very successful football player, was very successful after the NFL. I learned about a month ago that many people in Chicago thought he should run for mayor. He was so popular. He had been a successful businessman with Duerson Foods. He was very active in the NFL Players Association, and he was doing quite well until about 4 years before his death, when he started developing some work and financial difficulties, which resulted in his loss of the company. He became physically and verbally abusive. His wife filed for divorce, and he noticed that the headaches that really had bothered him since he left the NFL were worsening. He was having difficulties with his short-term memory, difficulty with word finding, and some blurred vision. And as you recall, Dave Duerson is the individual who shot himself in the thorax after texting his ex-wife that he wanted his brain donated to the NFL Brain Bank. And this is his brain. And you can see Dave Duerson has these very characteristic deposits of tau in his frontal cortex, which are worst at the depths of the sulcus. They also involve the medial temporal lobe. There's a perivascular component to this disease, and it's very, very profound disease when you look at it microscopically. There was no beta amyloid in this brain and no evidence of any other disease in the brain of Dave Duerson. upon neuropathological examination. This is Owen Thomas, who was a college player. He loved to play football. He'd played since he was 9. Never had a documented concussion, but was considered a hard hitter and loved the violence of the sport. He was a very popular student. He was unanimously voted team captain. He was considered sort of the life of the team. And then one day in April of 2010, he called his parents and uncharacteristically said that he was really stressed by school and he was concerned about failing 2 of his subjects. And a day or 2 later, he hanged himself in his off-campus apartment. And his brain was donated to our study thinking that he would be a control because he hadn't had any concussions, hadn't had any known problems. But lo and behold, when we looked at his frontal cortex in the depths of the cerebral sulci, we see these same characteristic lesions in the brain of this 21-year-old, a brain that isn't even fully developed at this point. He's already showing signs of severe degeneration. And if you compare the brain of Owen Thomas, dying at 21, to the brain of Dave Duerson, you can see that there are many, many parallels, and it's easy to imagine that if Owen Thomas had lived 30 more years, he might have developed the profound abnormalities we saw in Dave Duerson. Owen isn't the youngest player we've seen these changes in. We've seen it in an 18-year-old football and rugby player in high school, and we've also seen very minimal changes in a 17-year-old who died as a result of second impact syndrome, Nathan Stiles, who was actually the subject of a CNN report back in January. It doesn't affect just football. There's also hockey. We've seen it in a number of hockey players, but this is the case of Derek Bugard, who you may recall was an enforcer, or that was his role on the team. His statistics were 3 goals, 489 penalty minutes, and multiple regular season fights. He was actually sidelined at the time of his death because of he was having difficulty recovering from a concussion he'd sustained during a fight. His parents reported some problems with feeling depressed, being very emotionally labile. He had impulsive spending sprees, memory loss, disorientation and intention, but it wasn't clear to us or to his parents if this was related to brain difficulties or his problems with drug addiction, because he was in and out of rehab at the time. He died at age 28 from an accidental overdose of oxycodone and alcohol. And this is the brain of Derek Bugard. Again, seeing those very characteristic lesions, the depths of the sulcus and the frontal lobe beginning to involve the medial temporal lobe. And when you looked microscopically, those very same changes we've been describing in the other brains. More recently, actually just a couple of days ago, we reported the same changes in military veterans. This is a 45-year-old veteran from the recent Afghanistan-Iraq conflict who had a single close-range blast exposure. He lost consciousness briefly, and from the time of the blast exposure until his death 2 years later, he had headaches, irritability, difficulty sleeping and concentrating, as well as depression. He died from a ruptured aneurysm, and when we looked at his brain, he had many similarities to the brain of the athlete, having this very pronounced perivascular tau abnormality, which again was worst at the depths of the sulci. This is a second OIF veteran who had 2 separate blast exposures. Afterwards, after his second exposure, had persistent depression, memory loss, word-finding problems, loss of attention, concentration, sleep disturbance, and was diagnosed with PTSD. And again, we find these characteristic changes in his brain and the frontal cortex. This is a 22-year-old recent veteran of the recent conflict who died of an intracerebral hemorrhage a year after his exposure to the blast. He also had daily headaches, memory loss, depression. And this just shows you the axonal injury that we see in these individuals. It's a very subtle change. It's best seen actually electron microscopically, but we do see abnormalities of the axon. And in this instance, this is actually a 4-centimeter axon that's in his external capsule that you can see is filled with phosphorylated tau. So phosphorylated tau abnormalities in these individuals at very young ages. If we compare the blast-injured veterans to the young athletes, you can see that there are considerable similarities in their neuropathology, and this is the subject of a recent paper in Science and Translational Medicine. And we're working, I think what's important about that paper is that we're working on the mechanism. We're working on how these changes occur, what happens at the microscopic, molecular level, how does this occur, because certainly we don't want to keep describing this disease in dead athletes and veterans. That is not the focus of our work. Our focus is to help people to figure out a way to treat and reverse and stabilize this disorder. And the way to do that is to understand the mechanism at the cellular level. How does this injury, how is it triggered, and how does it progress through the nervous system? And that's what we're hoping to do with this mouse model of blast neurotrauma that Lee Goldstein has developed at Boston University. And we've seen similar changes in the mouse brain that we found in the soldier's brain. And I won't get into that in detail at this point, but I think it does give us optimism that we can use some therapeutic interventions in this mouse, test to see if they protect the mouse from developing these cellular abnormalities, and hopefully develop prophylactic and treatment modalities for living athletes and living soldiers. So this is just a montage of some of the cases, about 25 of the cases. But you get an idea that we are seeing a whole range of abnormalities. We're starting to see what happens in the very earliest stages of this disease and what it looks like in very profound disease. We've begun to divide it into 4 stages of increasing severity, starting out with these very focal abnormalities in the frontal lobe, progressing into a spreading pathology throughout the frontal lobe, and then becoming that more severe pathology that I've showed you in previous examples. Most of these individuals with this very early disease are asymptomatic, but we see about 75% of individuals are symptomatic in stage 2 with things like depression, headaches, attention and concentration loss, irritability, and those aggressive tendencies. Short-term memory loss becomes more prominent in stage 3, and then as the individual ages and the disease becomes more profound, this is where we're seeing severe dementia and Parkinsonism. I'm not going to get into the ALS component because I think I've run out of time, but we also see an ALS component. This is just another athlete who came down with ALS. I'm just going to show you briefly that his brain looked identical to the rest, a BC college football player who came down with ALS and some memory disturbances, and you can see that he clearly has the same characteristics of CTE that I showed you before. So what do we know? We know that CTE is a progressive neurodegenerative disease, that it's not Alzheimer's disease. We're finding it in the brains of football players at all levels, boxers, hockey players, and military veterans. In all cases, it's been associated with repetitive, what we call mild traumatic brain injury, even though mild traumatic brain injury is a misnomer because it's not so mild in its consequences. Usually those traumatic injuries occur early in life in a person's teens and 20s. Once triggered, the evidence suggests that the neurodegeneration progresses, and it progresses slowly over many decades to involve widespread regions of the brain. The earliest symptoms of CTE are usually quite subtle. They begin in midlife with these personality changes, behavioral changes, depression, impulsivity, irritability, and memory loss, and that slowly deteriorates into profound dementia, gait and speech disorders, and Parkinsonism. We're starting to see the spectrum of pathology in CTE ranging from those very focal early changes to widespread disease. We're correlating the symptom loss with the stages of disease, and we're also showing that the pathology that we see in athletes is very similar to the pathology we're seeing in combat-associated injuries. There's a lot of things we don't understand. We don't understand the genetic risk factors. We don't think everyone who's going to get this disease. We know that some people are more susceptible than others, but at this point, we still do not know what distinguishes those who are resistant from those who are susceptible. We're focusing on how to diagnose this disease during life. Bob Stern at BU and my colleagues at the VA are looking at CSF tau as a biomarker to try to detect this disease during life. And we're also looking at neuroimaging, including using tau biomarkers as a neuroimaging tool. We can't treat these disorders, but we're hoping that understanding the molecular mechanisms that give rise to this pathology will enable us to focus our treatment on targets for intervention, and we're hopeful that the blast neurotrauma model leads us to effective therapies. And finally, preventive education and increased awareness of concussion and its management in both sports and the military will decrease the frequency of this disorder. I want to thank all the people that are involved in this work. I don't have time to go through them. It affects all the people, you know, it's many parts of life, civilian life, our kids, athletes, our military, and thank you very much.
So we started with Dr. McKee's talk for two reasons. One is to sort of set the stage of why this is an important conference, and the other is because she has to leave early. So I think it works perfectly to get towards the basics. I think one thing, and we apologize for this, but we have a really full program of what we thought was very important stuff. There will be some time for questions, but we don't have as much question time as we would like today.
But Dr. Cantu will be here, and he can answer all the questions.
So, but for all of the speakers that are here, we're happy to talk offline, and there will be some question opportunities during as well. Next up is someone that was not on the original program, but we have Dan LaCouture, who was many years in the NHL. He's a Massachusetts native, born in Hyannis, went to Natick High, where he and his brothers knew Doug Flutie and his family, and was drafted in 1996 in the NHL as a second-round draft pick and played for many years for various teams in the NHL. And Doug, one of his family members, is a patient at Children's, and Doug has been to Children's many times and really was interested in both hearing Dr. McKee's talk and sort of reflecting on his own experiences. So we invite Doug, and his wife is here as well to hear about some of this. Thank you, Doug. Dan.
Thank you for having me. My name is Dan LaCouture. Dr. Proctor, Dr. Groom the Rover called me this week and asked if I'd be happy to come up and speak. My sister was a patient at Children's Hospital twice for, she had went through 2 brain tumor surgeries. This is my first time publicly speaking. I played 15 years professionally and 9 in the NHL, 1 being with the Boston Bruins. My first known concussion was back in 1997 while I was playing at Boston University. I played there for 1 season, and before that I don't know if I had any concussions or didn't really know too much about it, but in 1997, while I was playing for Boston University, I went headfirst into the boards, and then I was told that I had a concussion, and so that I had to miss some time. I ended up missing maybe 5-6 days in between games, but again, I wanted to get back out and play. Following that, I've gone through 14 concussions, 6 documented. And why you asked the other ones weren't documented were because, I just wanted to play. Didn't, as an athlete, you don't want to lose your job. And, if you're out a certain amount of time, then, the guy's gonna take your job, and it's gonna be hard to get back and play. And, but I played at BU for 1 year. I turned pro at the age of 20. First training camp was 1998 in Edmonton. The following year is when I suffered a really severe concussion in training camp. I ended up missing a month, and I do have to give credit to the Edmonton Oilers organization. For back at that point in time, they were really cautious with their players and how quickly they would return to action. So I missed a month, came back, and I think first game ended up getting into to a fight. But my role as a hockey player was I always loved to score goals, but to be like a Cam Neely type player, to be that power forward and get in the corners and give the big hit, take the big hit, and then so that following that 98 training camp, I might have had a few bumps along the way, either from hits or fights that just felt a little oozy, but nothing really worth mentioning to the trainer. And then while I was in Pittsburgh in 2001, I suffered another concussion. I caught the helmet of a player. He was smaller, and we both happened to be turning, and his helmet caught me on the jaw and knocked me out. I don't know, 5 to 10 seconds, and I just remember that plane ride home back to Pittsburgh from New Jersey, and just feeling sick and nauseous and just not right. And I ended up missing a week from that point. But again, I didn't want to be out. The team was going on the West Coast, and so I tried my hardest to pass that test, the neuropsych test, to get back to play. And I met the team out in California about 5 days later. And then I think the most severe concussion that I went through was while I was playing for the New York Rangers back in 2004. I got into a fight with another player. My helmet somehow jolted off, and towards the end of the fight, both the player and I went down, but his whole body ended up on my torso. So when we fell to the ice, the weight of his body on top of my torso just flung my head to the ice, and it split the back of my skull open. And there was a pool of blood, and I had to get rushed off, and the doctors had to quickly stitch up the back of my head. Amazingly enough, I came back 5 days later, and I didn't want to miss any time. Playing in New York, there's a whole slew of guys waiting to take your job. So my first game back was against the Philadelphia Flyers, and I just remember after the second period just telling the trainer that I just didn't feel good. My stomach, I just felt oozy, I felt sick, and so from there they said that was enough, and I ended up missing about 6 weeks of time after that. And in hindsight, that was back in 2004. I probably should have never have come back from that injury. It's probably the worst concussion I've suffered in my career. I haven't felt the same since then, and but I ended up playing another 8 more years of hockey, and then just a year and a half ago, I broke my neck playing while in Norway. I went headfirst into the boards, fractured my 7th vertebrae, and ruptured the disc between 5 and 6, and also suffered another concussion. And so I was happy to come up and speak here today, and also to sit and listen to the other doctors, because I haven't done enough myself to educate myself. And I've just been ignoring a lot of what's been going on. And I think when Dr. McKee showed those symptoms, pretty much all of them, I feel, and so the more we can, the more I can educate myself and hopefully help educate others. It's important, and I like to be more active going forward, and whatever way I can help, and share my stories and educate myself. I brought my wife today because she's the one that's got to live with me at home, and so she sees firsthand what changes that have occurred with me. And I know my father always says to me, he's like, why are you so irritable these days? Why are you so short? Why are you so upset? And I'm like, I don't know. I just really get irritated quickly and get angry and depressed, and you know, it's a high and a low. You know, some days I'll be really happy, and then some days it's just, you know, just rock bottom. You know, I do see somebody. I live on Cape Cod. That's where my wife's from, and it's where we raise our 2 kids. And you know, I do see someone once a week back home, but you know, I don't think it's enough. You know, I need to you know, I need to learn more about this disease, and so.
So I think Dan has offered to take a couple of questions. We really only have a minute or two, but if anyone has a question for Dan.
I appreciate that. And
And just so for those who couldn't hear, it was just a comment that Dan would do great speaking to students throughout the state and the country. There are microphones too, if anyone wants to be heard a little bit more. Maybe time for just one more question or comment.
yeah, that's
I'm sorry, just if people didn't hear, it's basically, do athletes cheat on the baseline neuropsych testing so that after the concussion their score can seem more consistent with their baseline?
That's a great question. When I was in Pittsburgh, I remember the neuropsych test before camp, and yeah, I would purposely be slower on things, knowing that going into an 82-game schedule that I'm going to take my bumps and bruises, and if I get a concussion, that I didn't seem too far off that test. So on my team, I don't know, you know, but I know around the league, I'm sure I wasn't the only one.
Thanks so much, Dan. And Dan. People want to talk to you afterwards. I certainly would never admit to all the cheating I did to get here. So Dan's going to be here throughout the day, and I said he'd be happy to talk to people as well. For those standing, there are definitely seats if you just want to come down and move into the seats. So next we're going to sort of backtrack back to the basics, and we're going to really start talking about concussion as an entity. And I'd like to invite up Bill Meehan, who's one of our course co-directors and the head of the Sports Concussion Clinic here at Children's Hospital. Bill is quickly establishing himself as a leader in this field. He's published a book. He's got loads of articles out about the subject, and he gives a great talk.
Sorry. On June 6, 2011, the Boston Bruins were playing the Vancouver Canucks in Game 3 of the Stanley Cup Finals. And Nathan Horton, who's featured there, had just passed the puck to his teammate Milan Lucic when he was struck in the face by Aaron Rome. This accelerated his head backwards toward the ice. Just for good measure, Rome kind of raises his elbow and speeds Horton along. And you could see just before he strikes the ice that the occiput, the back of his head, is about to be the first part of his body that hits the ice. It does. it rotates his head forward. He's knocked unconscious. His eyes roll back in his head. His arms come forward in a convulsion, what we call a concussive convulsion, and a clonic bear hug type posturing. And he remains unconscious when the athletic trainer for the Bruins, Don Del Negro, reaches him on the ice. What seemed like eternity if you were watching on television, but was realistically probably 30 seconds later, he regained consciousness, and he had no idea where he was. It's the biggest moment of his life, right? He's playing for the national championship in his loved sport. He has no idea who that guy is. Don Del Negro, the athletic trainer, he sees every single day. He was eventually boarded and collared and taken to a local emergency department where he had a CT of the brain that was entirely normal. There was no swelling, no bruising, no bleeding, no skull fracture. None of the cells went on to die. So why, if his brain is normal, is he knocked unconscious? Why, when he regains consciousness, does he not know where he is, even though it's the biggest moment of his life? And why does he not recognize a man he sees every day? That's what concussion is. It is brain dysfunction in the setting of a structurally normal brain. And that's what we're going to talk about today. I think of it, I define concussion as trauma-induced brain dysfunction. That's really all it is. The brain stops functioning properly as a result of trauma. The international consensus on concussion in sports has come up with a definition that lists several major characteristics. Number one, it's caused by trauma. We'll see in a little bit that the signs and symptoms of concussion overlap with many other diagnoses, and so really, it's got to be triggered by trauma. Number two, it's due to a rapid spinning of the brain or a rotational acceleration of the brain. And the easiest way to spin a brain is to hit it in the head, right? But you don't have to be struck in the head to get a concussion. You can imagine if you are wearing a lap and shoulder belt in a high-speed motor vehicle collision, when your car stops, your head will spin and rotate forward. And so in sports, certainly getting struck in the head is the most common mechanism, but you don't have to be in order to get a concussion. The signs and symptoms of concussion start immediately or near immediately, right? Really at the time of impact, and then they gradually improve. Most concussions will resolve without you doing anything as a clinician, although there are things you can do, and we'll talk about them. But they resolve on their own. And lastly, it is a disturbance of brain function as opposed to a structural injury. And therefore, you cannot see it on CT or standard MRI, our current neuroimaging modalities. I keep saying it's due to spinning or rotational acceleration of the brain. And I just want to go through how that played out in history because A, it's fascinating, and B, I think it helps remember what we're talking about here. It turns out that 100 years ago, men working in slaughterhouses knew that the head had to be free to accelerate in order to cause a concussion. And the reason they knew it was if you eat meat of any kind, of course, you go to the supermarket and you buy it, but somebody has to kill the animal, slaughter it, butcher it, wrap it up nice so that it looks appetizing. And those guys working in slaughterhouses 100 years ago thought it was inhumane to simply walk up to an animal and kill it. And so they would stun it. And the way they would stun it was by concussing it. So the one guy in the house would chase the animal through a wooden maze. And as it came out of the maze, there was another man who would pull a lever on this big metal trap that would close and hold the animal still. And a bolt would drop down from the ceiling and strike it in the head, and the animal would be stunned, somnolent, maybe unconscious, and then they could go about their business of the day. And these guys 100 years ago knew that if you held the animal by the head, which, by the way, made the job easier because then you could just put it underneath the spot where this bolt would come down. But if you did that, you would not concuss the animal. You would lacerate the scalp, fracture the skull, you would get blood in the brain, but the animal would be otherwise normal. Be angry, of course, scared to death probably. But it would not be somnolent, it would not be dazed, it would not be off balance, it would not be knocked unconscious. However, if you immobilize the animal by the body, so that after the bolt struck it in the head was free to move, it would be dazed, off balance, somnolent, often knocked frankly unconscious. So 100 years ago, men knew this. Now, I'm sure they didn't talk about it. It was sort of a practical reality. It wasn't something that they found fascinating, but they knew it. The world of science sort of caught up about 40 years later. And I'm going to talk about experiments really by two investigators, Denny Brown and Russell, who were studying brain trauma in animals in the lab. And the way they would deliver the brain injury, they had a weight on the end of a pendulum, and it would swing down, hit the animal in the head. And they noticed the same thing. If we hold the head still, it's easier to strike it with the pendulum because we just put the head where we know the pendulum's going to come down. But if we do that, we lacerate the scalp, fracture the skull, but we don't produce unconsciousness, we don't produce somnolence, disorientation, imbalance, nothing. If the head is free to move after impact, then we get signs of concussion. Now, as always happens in medicine, you establish something and then debate ensues. So they sort of established, yes, the head has to be free to accelerate to cause a concussion. And then people started talking, is it just acceleration? Is it linear acceleration? Is it rotational? This still gets debated in the literature, although I don't see why. And I'm going to tell you why I say that. The first person to really address this was a physicist, not an MD at all. And he thought about the physical properties of the brain, which, as you know, is mostly water. And he said, I bet you the brain behaves similarly to water. And if I were to take a glass beaker filled with water, put some feathers on top so you can see how the water moves, and I applied a purely linear acceleration, I pushed it in a straight line. When the water stops, when the beaker stops moving, the water will kind of wave, right? The feathers will bob up and down. But their relative position to one another will not change. Bob up and down, eventually stop, and it looks the same. If, however, I take the beaker of water and spin it, feathers go flying everywhere, right? So this guy hypothesized, he said, I bet you spinning or rotational acceleration worse for the brain than linear. And he built a gelatin model and put it in a wax model of a skull and did that. He rotated, he applied a rotational acceleration. And when he took it out, there was lines of cleavage through his gelatin model of the brain. And he was the first to describe shear strain. And his conclusions were rotational acceleration, bad for the brain. Now, people said, look, that's jello inside of a wax skull is very different than a human being. And so the debate continued until the 1970s when Omaya and Gennarelli did an experiment in monkeys. They took 24 monkeys, separated them into two groups of 12, put a helmet on them, and attached it to a piston. For one group of 12, they applied a purely linear acceleration. Bam! Move the head forward 1 inch. Those monkeys were sort of worked up, scared, but had no perceptible signs of concussion. In the other group, they rotated the head very rapidly over an arc of 1 inch. All 12 monkeys were immediately knocked unconscious. So these guys said, look, it's rotational acceleration that causes a concussion. A couple things to note about that. There was no blow to the head of these monkeys. They just had their head moved. Perfect straight line or rotation. So really, the brain was not bruised or punctured or had no problem. It was just the rotation caused the problem. Number two, in life, nobody gets a purely rotational or purely linear acceleration of the brain, right? Bam, you get hit in the head, you get both. But it's the rotation, it's the spinning that causes the problem. Now, maybe you could do it with purely linear acceleration. People say in the literature, linear versus rotational, right? But it would require a heck of a lot more force. And since life, you get both. It's really the rotational part that's causing the injury. Now, why? Why would spinning the brain cause a problem at all? And for that, you have to remember the way the brain works. So this is my sort of depiction of a neuron, okay? This is just what I try. So on the left-hand side is the cell body. There's a long axon and then a terminal end. And on the outside of the membrane of the axon is sodium, normally, in life, okay? And when that nerve cell, it's time to work, it's going to send a message, right? The first sodium molecule nearest the cell body moves into the axon. This is the action potential, right? First sodium moves in. Its presence there triggers the next one to move in. The presence of the second one going in causes the third to go in and the first to come back out, right? People remember this? I think of it as if I were to lie a rope on the ground here, right? And I'm the cell body at one end. If I pick up the rope and I put it down wicked fast, you get that bump in it, and it kind of travels all the way to the end of the rope and then, boom, lays down again, okay? You would be conducting an impulse from one end of the rope to the next. That's the way I think about it. This is the same idea. Sodium goes in, boom, next one in, right? Until it gets to the terminal end, and then squirts out a chemical. And the chemical triggers something to happen. That's the way it normally works. And what happens when you rotate the brain quickly, you apply a shear strain to the neurons. the channels that allow sodium to move open up all along the course of the neuron indiscriminately throughout the brain, not in a nice organized fashion where the first one goes in the next one and the next one, but just randomly all over the place, and sodium rushes in. And so you cannot conduct another action potential. You cannot use that nerve cell again until you restore sodium back to the outside, until you return it to its normal level of homeostasis. And that takes energy, right? In the body, energy is ATP. You eat something, stomach breaks it down into glucose, goes in the blood, brain cells suck the glucose out of the blood and make ATP, all right? So you need ATP to put sodium back on the outside of all these cells, and unfortunately, for days, weeks even after a concussion, there is decreased blood flow to the brain. You need more blood flow to get more ATP to fix this, but you're delivering less. And that mismatch results in the continuation of signs and symptoms of concussion. Does that make sense? Yeah. You can imagine if you steal glucose away from the brain to other parts of the body by skating or running or lifting weights, it's going to take longer for the brain to recover. And furthermore, if you use your brain to study calculus or play video games or something else that demands a lot of concentration and memory, you are stealing glucose from the activity of healing and putting it toward the other things you're doing with your brain. And so those activities will make you feel worse and potentially prolong your recovery. Now, there's lots of other stuff that happens, okay? But I know that nobody in this room cares about all the other stuff, right? And I suspect many of you didn't really care about sodium either, but I think it's a good way to conceptualize what the problem is and why spinning the brain would cause it, okay? So I'm just giving you a part of the story. Now, why do we care? So there's four main reasons, okay? Number one, an athlete who sustains a concussion in sports is at risk, at higher risk, for more concussions than an athlete who's never sustained them. You get one, your risk of getting more goes up. Number two, the effects are cumulative. Every time you get a concussion, it leaves some lasting effect on the brain that never goes away. Now, if you get one or two and you heal and recover properly in between, probably never going to cause you a problem, okay? I only know it's there because when you get additional ones, you behave differently than someone who's just getting there first, okay? So with a few concussions, you heal in between, you get managed properly, it's going to be fine. But the point is, it's cumulative. And when you get beyond just a few, you can have problems later in life, like Dr. McKee was talking about. Third is something called second impact syndrome, which we'll review in a minute, although I suspect most of you have heard of it. And lastly, chronic traumatic encephalopathy, which I will not talk about because there are experts here doing that. I'm going to skip this just for time's sake. We're running behind and we have to be close today. I do want to talk about the cumulative effects, though. So in 1975, a neuropsychologist named Dorothy Gromwall separated patients that came to her clinic into two groups, those who were there with their first concussion, those who were there with their second. And she noticed that if you were at her clinic with your second, your brain function was worse than the guys who were there with their first concussion, and it took you longer to recover back to normal brain function than those who were there with their first. And so she hypothesized, hey, I think there's an accumulative effect, right? Every time you get one, it has some effect that doesn't go away. Now, people debate this. Some people feel that the problems with former professional players is that they went back before they were fully recovered and kept getting more, but that if they had recovered in between, they wouldn't have a cumulative effect, all right? Now, I would agree that it is worse if you don't recover in between. But Dorothy Gromwall's patients were not athletes. I mean, some were, but I'm just saying they were not on the whole athletes. The average time or the mean time between concussions in her population was 4.5 years, right? So nobody's still recovering 4.5 years later, right? And it's rare in life to get a concussion if you don't play sports. It's wicked rare to get two, okay? So they were separated a lot in time, and still there were cumulative effects. And since then in athletes, there's been multiple studies showing this, and we have a model in mice that also show this. Second impact syndrome was described in 1984 by Saunders and Harbaugh. They described a college football player who was 19 years old. He got in a fist fight on a weekend, not football related, but sort of out, got in a fist fight, was knocked unconscious by the other combatant, had headaches, nausea, vomiting, went to the school infirmary, stayed overnight, and ultimately was sent out. And a couple days later, he reported to practice, and he said, I feel good. I still have headaches, I'm a little nauseous, but I feel good. and he was cleared to go back to football, which, by the way, back then was common. This was not like gross malpractice. This was a common practice to do back then. But he went back and nothing happened. Nobody remembers anything. No major blow to the head, nothing that anybody thought was unusual, and yet he walked to the sideline and collapsed. And he was taken to a local hospital where, despite some very heroic measures, including a craniotomy and evacuation of a small subdural, he died. And at autopsy, he was noted to have cerebral edema and hypoxic damage, and he herniated. And they hypothesized, they said, we think he was set up for this catastrophic injury because he was not yet completely recovered from his concussion. And since then, there's been multiple case series. Dr. Cantu has published some of those showing the exact same thing. And that's what second impact syndrome is. These guys were the first cases, well, Mike Webster was the first case, and then some other famous cases of chronic traumatic encephalopathy. I just want to bring it back to your attention. That's why what Ann McKee was saying this morning is so important. So how do you assess concussion? Now, I would say if you're at rink side or field side when this happens, your real job is to rule out other injury, okay? You respond to what seems to you like a concussion as you would any other injury. A player's knocked unconscious, Nathan Horton's laying there, you're Don Del Negro. Your first issue is his airway open? Is he breathing? Is his heart pumping? Because really, if he has a concussion at that moment, who cares? You're going to fix that, right? But not right now in the middle of this on the ice, right? Your real concern is other injuries. Did he fracture his cervical spine? Does he have an intracranial hemorrhage? Does he have cerebral edema? Those are the things that you need to worry about acutely. The concussion we'll get to later. And so I would say, despite all the media attention and panic, when an injury happens, that's not your main concern at the moment, okay? Now, the history of concussion, the classic history, is I was crossing the center line and I lost control of the puck. I looked down to regain control and someone hit me. And all these things started. I got headaches. I felt nauseous. I was off balance. I was confused. I started skating the wrong way. But gradually, over the last few days, I've been getting better. Not yet 100% normal, but I'm gradually improving. That is the history of concussion. Now, history is important in everything we do in medicine, but for concussion, it's key. And if you don't get that classic history, you ought to worry about something else. If the symptoms started a week later, you ought to think maybe it's something else. Could it be concussion? Sure, I don't know. Maybe they didn't. But look for something else. Don't assume it's concussion. If their symptoms are getting worse as opposed to better, you ought to worry about something else. Do they have a small subdural? It could be that they're working out or studying and there's a reason they're getting worse. Okay, then you might take that reason away and allow them to rest. But if not, if they're getting worse, you should think about imaging. The reason imaging is in parentheses, you can't see a concussion on standard neuroimaging. You would get it, though, if you don't have a classic history or you have something abnormal on your physical exam, not because you think they have a concussion. You get it to rule out something else that might be causing their symptoms. These are the signs and symptoms of concussion. And like every other illness known to man, right? This is not a specific list. This could be anything. I feel sad, I got headaches, I got low energy, I'm a little confused, right? Could be depression. Maybe you just got, your girlfriend dumped you. Could be hungover. I mean, there's a lot of things that will cause those signs and symptoms. And so that's why history is so important. If it all started when you had some rapid spinning of your brain, that's likely to be concussion. If it didn't, if you say, look, I play football, I don't know, now I have headaches. Might not be, all right? Probably not. Look for something else. There are some standard assessments we use to help evaluate athletes with concussion. If you just ask an athlete, do you feel okay? Are you ready to play? They're always going to say yes, always. They want to play. This is what they do. And we allow them to do that, right? If you have an AC sprain, we let you play if it hurts, you know? I mean, this is a fact for an athlete. And so they don't think of concussion as different. Bothers me a little, but not so much that I can't play. And so you have to be more specific. I use the post-concussion symptom scale proposed by Dr. Cantu and his group at the International Consensus on Concussion in Sports. I'll show it to you in a second. Another objective way is to measure their balance. For those of you coming to the afternoon session on the medical treatments for concussion, we'll go through this. And then lastly is neurocognitive testing or neuropsychological testing, which some of my colleagues are going to talk about later. But there are ways you can do it. This is the symptom scale proposed by the International Consensus. And so instead of just saying, are you okay, you ask them specifically, do you have headaches? Do you have nausea? Are you having trouble with your memory? Are you having difficulty sleeping, etc.? They rate them on a scale of 0 to 6, okay? The balance error system score, I just want to go through how it became validated, because I think people read this and they say, this is a very gross assessment of balance. How can this be useful? A PhD and athletic trainer at University of North Carolina, Kevin Guskowitz, developed this by doing what's called posturography. You sit in the middle of all these sensors, and he puts you in positions with your feet together, your eyes closed, your hand on your hips. Another position is one foot in front of the other. Another position is just on one leg. And he measures how much you sway, okay? And it turns out that after a concussion, you sway more. Your balance is worse. You have a harder time balancing, and you sway more. And then it gradually returns back to what it was before you got your injury over time. But the machine's $100,000. And so most clubs would not get that, right? Most colleges, even pro teams, high school teams, certainly not around here, most of the high schools, will not buy that, don't have the resources for it. And so he developed this score scale. It correlates with what he finds on posturography, not 100%. It's about 85% sensitive compared to the posturography, but it's practical. You could do it in the office, you could do it in the athletic training room, you could do it on the sidelines, okay? And the idea is you get a baseline measurement of their balance, and if you suspect a concussion, you repeat it and you compare it to their baseline, all right? Much like we do with neurocognitive testing. These are the errors, right? So you put them in those 3 positions for 20 seconds each. Every time they do one of these things, put their foot down, open their eyes, lift their hand off their hips, they get an error, all right? And then finally, neurocognitive testing. How am I doing on time, by the way? I'm okay? So. I'm going to finish up soon. So I just want to, they're going to talk about what it is and how you do it, et cetera. I just want to emphasize the importance of it. So this was a patient in our clinic, a 12-year-old female. On the y-axis is the percentile, where she scores in relation to other 12-year-old females throughout the country who play basketball. The colors each represent a composite score, a sort of score of assessment of brain function, okay? The blue is her ability is her verbal memory, okay? There's a lot of different paradigms in it, actually, but the red is her visual memory. The green is the amount of time it takes her to sort of process information and come to some conclusions on the exam. And then purple is her reaction time. Every time she sees a certain stimulus, she's supposed to hit a button on the computer as fast as she can, and it measures her reaction to 1/1000th of a second. Baseline is before she ever got hurt. Before she ever played basketball, she had her brain function measured. And she is a highly functioning young lady, right? She's like 85th to 100th percentile in every category. She's wicked smart, right? She then gets a concussion, and 6 days later, she goes back to this athletic trainer. He repeats her test, and those are her scores. Markedly different. And imagine for a second, she's not 12 and she's not in 6th grade. Imagine she's a junior in high school. And these grades are going to determine her job or whether she goes to college or where she goes to college. And she comes in and says, look, I can't take the test today. I've got a concussion. And her teacher says, you look okay to me? No bandages, no cast, you're not on crutches. I don't understand. You're in school. Take it, right? She will do worse. Just no question, right? It'll take her twice as long to finish the test as it normally would. And this athlete gets better quickly, but we have loads of people in our clinic who take 3-4 months. And their teachers think they're lying, and their friends think they're lying, and their parents think they're lying, they're malingering, right? But this, they're not. This is what happens. Now, eventually, her symptoms went away, but when she came in 16 days later, she felt fine. She said, I have no headaches, no nausea. I've made up my schoolwork. I'd like to go back to basketball. And if it had been 5 years earlier and we didn't have this testing, I would have cleared her. I would have said, great, start the return to play stages, right? This is why it's important to have this component, if you can. 20 to 30% of athletes will report being symptom-free before their own brain function gets back to normal. And so if you don't have this data, you risk putting them back to play too soon. So we waited. We had her come back a week later. Everything was back to normal, and she went back. But that's why this test is important, and I will let my colleagues talk about the rest of it in detail. So how do you manage it? I'm going to stop here, even though I have more slides. It's simple. So I would say everybody in this room should own the management of concussion. I don't care what your specialty is or what type of letters you have after your name. The beginning stages are simple. Number one, you rule out other injury. You make sure they don't have an associated cervical spine injury. You make sure it's not a subdural or something else that's causing their symptoms. Once you've established it's concussion, you put them at rest. physical rest. They avoid working out so that you're not stealing ATP and glucose away from the brain. You put them at cognitive rest. Avoid things that demand a lot of memory and concentration and focus. So again, you're not stealing glucose and ATP away from the healing process. And then, when they're symptom-free, with full cognitive exertion, when they've made up all the missed schoolwork, when they're symptom-free with non-contact physical exertion, and when their baseline assessments, balance and neurocognitive, are back to normal, you put them through the return to play stages as recommended by the international consensus in sports. You start with light aerobic activity. If it does not bring back their symptoms, great. You move to more rigorous activity. If that doesn't exacerbate their symptoms, they do sport-specific training and eventually non-contact practices, etc. Okay? Everybody in this room can do that. And since the vast majority of athletes who sustain a sport-related concussion will recover quickly, a matter of weeks or months, that's all they're going to need. All right? We'll talk about the other stuff later, but for the vast majority, they need conservative management, and everybody in this room can do that. So.